Hello, everyone. I'm Mary Beth Marsden, and welcome to GBMC's Ask the Oncology Expert. I love today's conversation because we're going to be talking about survivorship. So I think by the very nature of it, it sounds empowering and hopeful. And we're so glad to have with us today Dr. Robert Donegan. Dr. Donegan, thank you for being with us. You are the Chief of the Division of Medical Oncology, and great to be joined by you today.
Hi, Mary Beth. Great to be with you as well. Thanks.
So it is really so uplifting to talk about what it means to be a cancer survivor. And I hope that everyone sort of embraces that role if indeed they are. Can you talk about what that means to you and what that should mean to your patients?
Yeah, so the word survivorship can mean a lot of different things. I mean, I think one of the definitions that a lot of people would think about was somebody had been through initial therapy for their cancer. Maybe they were done the therapy and now it was time to be called a survivor. And I think that's kind of a dated reference. I think that the way that I think about survivorship is in a much more broader umbrella, and that is that from the moment somebody is diagnosed with a cancer, a malignancy, they are at that point a survivor. And so survivor is a moniker that really lasts for the duration of their life at that point.
Do you find that these days most of your patients embrace that terminology, or does it take them a while to sort of get there?
Well, it's really individual. I think I would say that most do, but not all. Some people would rather get away from the word and use different phrasing. Some will say, well, I'm living with cancer, or I've had some that call themselves a thriver rather than a survivor, just a play on the word. I think it can mean so many different things because people are in such different trajectories in this realm of survivorship. It could be somebody that is diagnosed with an early stage cancer, which is fated to never recur, and they've had their initial therapy, and the cancer never revisits them. Or it could be somebody who's diagnosed with an early stage cancer that later does recur, or develops a second cancer of a different sort. Or of course, it could be somebody who is diagnosed with a more advanced malignancy or a more chronic malignancy that they live with for the duration of their life. So it really it's a big circus tent that includes a lot of different life stories.
I'm sure in your role too, you've gotten pretty good at being able to sort of determine where this particular patient is in their view of their cancer, and you sort of adjust to that.
Yeah, I think we have to always meet patients where they are and understand where they are and start with that.
When GBMC, the thing I love about GBMC is that it is a team approach. When you're a patient, particularly if you're a cancer patient, you have specialists, you have social workers if you need them. There's a whole team helping you as a whole person survive, thrive, whatever the term is that you're using. Can you talk a little about that?
Well, that's absolutely true, and we couldn't do it without that team approach. It requires so many levels of care, from the person you meet at the front desk as you're walking in, to the surgeon who's operating on you in the operating room. I mean, it really, at so many different layers, requires a commitment and a compassion that I think is really exemplified here at GBMC. We really work as a team, and it does take a village to care for each other.
I believe that you talk a lot about being holistic, having a holistic approach. What does that mean exactly?
So I think that's really relevant to this notion of survivorship, and so much of the focus is on how to fight the cancer. What are the drugs that are to be used? What's the right dose of radiation? What's the right surgery? And of course that's all very important, but there's so much more to this narrative than just fighting the cancer. It's the mind, it's the spirit, it's the body, and so many other ways that are so relevant. So I think we really have to approach our patients in that very holistic manner, not only dealing with the cancer itself, but all of the things that go along with it, the side effects of medicine, the emotional overtones of going through a cancer experience, the financial issues and stressors. There's so much more to it than just what do we do about the cancer itself.
Yeah, I'm sure that at one point, maybe even in your career, there was a time when traditional medicine didn't always sort of see that aspect of a disease or a treatment. Is this something that you've sort of grown into, or just really started to embrace more and more, all these aspects of being a cancer survivor?
Well, I think we've grown into it by necessity because our patients demand it, as they should. I mean, I think it really requires a broad understanding, and the patients need it. They ask for it, and so we have to rise to their to the patient's needs. Again, we have to meet the patients where they are, and these are very important issues for patients. Um,
We gathered a lot of questions from people who knew you were coming on today, and we're excited to ask you about their particular situations, and we want to get to all of them to be fair to those people who are watching. But I want to sort of set this up too, so that they know if they have questions live, they know where to go with them. So would you mind talking about what your primary focus is when you're treating patients, so that way we can sort of tailor some questions that may come in live to your expertise?
Yeah, so medical oncology and hematology is a vast area, and one thing that we've come to learn is that in order to serve our patients well, many of us have become somewhat subspecialized within the discipline. It's hard to do it all and do it all well. And so, for example, in my particular situation, I see probably about 60% of what I see is breast cancer, or women with breast cancer, I should say, and some men, but mostly women. And then a variety of other malignancies as well, blood-related malignancies, some blood disorders. Others in the practice have become more specialized within gynecologic malignancies or within head and neck cancers, for example. It's, things that I don't personally care for myself because that's not been my developed area of expertise. You know, the analogy I was thinking about on the way over here is it's almost like being in a rock band. You know, the person that plays the lead guitar is very talented at playing the lead guitar, but if somebody hands them a bass guitar, they can play that too. So you become very specialized in one area, but you still have a good ability to care for other malignancies too. They just may not be the majority of what you see. I hope that analogy works.
No, I do understand. And I am probably going to throw in a few COVID questions too, because it sort of changed the dynamics of how we operated for a while. I think we're getting a little bit
Sure.
back more to normal, quote unquote. I'm curious because you say you do see 60% of your patients have breast cancer related issues, but it might be too early to say, but there was a time when women probably weren't getting mammograms because of COVID for a long time, and I'm wondering if we have seen any repercussions of that.
So I think so. I mean, and I don't think we're going to know the full story probably for a matter of a year or two to know what the implications have been of delayed screening tests, mammograms, colonoscopies, et cetera. But we're certainly seeing our breast center very busy, and I think that's because people are catching up. They're finally feeling safe to come out and come to the doctors, and yeah, we're definitely seeing a bit of a post-COVID surge, for sure.
Okay, Dr. Donegan, I want to get right to these questions with the time we have. Some are coming in live, and I'm going to go to those first, and one is COVID related. One person wants to know, do you recommend that cancer patients continue to wear their masks no matter what the mandates are?
So we like to look to the CDC recommendations to guide us. We try to use as much evidence as we can to help us with those questions. A lot of it has to do with what their immunity is like. So if a cancer patient has some diminished immunity, either because of the condition for which they're being treated, for example, leukemia, multiple myeloma, or if the therapy that they're receiving is suppressing their immune system, such as chemotherapy, then we do consider them more vulnerable and more at risk of contracting COVID, and if they were to contract COVID, have a more serious course. So I do think precautions for the immunosuppressed are very important, and that includes wearing masks, especially when indoors, and hand washing, and being aware of who you're around. Hopefully, as we're getting more vaccinated as a populace, this will become less of an issue. But there's still a lot of people out there that haven't been vaccinated, and that's especially dangerous to the immunosuppressed.
I can tell that worries you,
Sure,
the percentage of people who have not been vaccinated.
sure, sure does.
Someone has a question about the vaccine. Given recent research that suggests that many immunocompromised people may not develop antibodies, I don't know if that's accurate or not, after receiving the COVID-19 vaccine, do you recommend antibody testing for these patients?
So that's a really important question, and it actually is true that we are seeing in several clinical studies, both here in the United States, out of France, and out of Germany, the United Kingdom, that there it does appear to be less of an antibody response uh, to the vaccines in those who are immunosuppressed. The challenge is knowing what to do with that. Um, we are not at this point recommending antibody testing be done for several reasons. Number one, even if an antibody is found, we can't say with confidence that that immunosuppressed patient is not still at higher risk because there's a lot of different legs to the immune system. And even though the antibodies may have been created, there still may be some vulnerability. So we don't want to give false reassurance to that patient that they can go about and not be careful. The other thing is that there's problems with the antibody testing, and there's a different antibody for the vaccine, and there's a different antibody for having been infected. And a lot of times people get an antibody test, and it actually ends up being the wrong antibody, and it's hard to really know if they were protected from the vaccine or not. So all of this is still really not clear. It is being actively studied, and I hope that we're going to have some good evidence and science to guide us by the end of this year so that we can be more smart about it. You know, one of the big questions that comes up is should those that are immunosuppressed get booster shots? And I think that's a question that's being very actively studied, and we hopefully will have an answer by the end of the year.
Someone wants to know, what suggestion can you give a cancer patient that has low energy and constantly feels sleepy?
The only reason I'm laughing is I know the feeling.
Yeah, right.
So, yeah. Fatigue is by far one of the most common symptoms that cancer survivors face, and it's caused by so many different things. So it's really important to approach that question with a broad scope, kind of cast a wide net, if you will, and look for a lot of reasons. You know, it could be a function of side effects from their therapy. It could be an issue with sadness and depression. It could be that they're not sleeping very well. Patients who are fatigued oftentimes are anemic, so there could be a drop in their blood counts. They could be iron deficient. Their thyroid gland could be underactive because they had radiation therapy to their neck. I mean, I say all these things just to make a point that there's a whole broad array of reasons why fatigue can occur, and I think it's important for the caregiver, the physician, or the nurse practitioner to really approach it with that broad base and really try to figure out exactly why they might be fatigued, and hopefully something can be done about it.
Yeah, so I guess what you're saying is you don't just have to accept it. You can really try or get someone to help you figure out what might be going on. Someone wants to know, will they have pills instead of traditional chemotherapy in the future?
So we already do have a lot of pills. I mean, there's been a real change in the last 30 years. There's a tremendous amount of oral medications that have come out that are part of our regular armamentarium. Some of them are oral equivalents of an IV medicine, and some of them are just standalone oral pills themselves. But we're seeing more and more oral medications being used, which is certainly a lot more convenient to the patients. And you know, there was an interesting thrust reinforcing this when COVID hit, because there were all these efforts to see how can we keep patients safely away from the hospitals if need be. And one of the answers to that was to, if there is an oral alternative, to use a pill instead.
What are your thoughts on mistletoe treatment?
Oh, that's a complicated one. So mistletoe is something that's commonly used. It's especially more commonly used in Europe. It was developed in Germany as a sort of a holistic therapy. The science behind it is not robust, although there are clinical trials that have shown that if mistletoe is used while going through therapy, it may, in some patients, help with fatigue. It's not a cure-all by any means. We really honestly don't know that it has a true anti-cancer effect, although it's been touted as doing that. There is a preliminary clinical trial that's been coordinated through Johns Hopkins that is several years in, and it will probably be at least many years away before we have an answer as to what is even the safe and effective dose for mistletoe. So I know that it's commonly used out there in this community especially, but I still think that the jury is out. It's definitely a conversation to have with your caregiver.
So I guess, and that's the important takeaway is if you are receiving treatment, don't just go out on your own and add something to that treatment if the doctor is unaware of what you're doing.
Yeah, I mean there are studies that have looked at vitamins and their impact upon cancer outcomes, and there are some studies that have shown that high vitamins can actually increase the chances of the cancer recurring or growing. Cancers need vitamins too, so just because it's natural doesn't mean that it's automatically safe.
How often do you believe breast cancer patients who have completed active treatment should be seen by their oncologist and surgeon for surveillance?
So it's not a set answer. It really varies depending upon the scenario. It depends upon how far they are out from their initial diagnosis, and also the seriousness of the cancer or how risky it is to recur. That said, in general, in the first 5 years, we'll usually see our patients every 4 to 6 months, and then as they get further out and become safer with regards to recurrence, then the frequency becomes less. Eventually, it goes to once a year, and at some point, God willing, the patient can graduate the clinic.
And this is another pretty broad question. I guess this would depend on the type of cancer, et cetera. If a patient has had breast cancer but has no family history, what are the chances of their cancer recurring?
So, if you look at breast cancer in general, about 20% of women who are diagnosed with breast cancer will at some point develop metastatic disease. So 8 out of 10 will not. Um, if there is a strong family history, and especially if there is an identified underlying genetic predisposition, those patients are at higher risk of developing cancer in the first place. Although interestingly, that doesn't actually increase their risk of recurring compared to somebody who has an underlying genetic predisposition.
What about the more aggressive form of breast cancer? Triple
So there are
negative
a few,
comes.
yeah, so triple negative breast cancer, that does have a higher recurrence rate than the 20% as a whole. And it really is individualized. It's based upon um, the age of the patient, whether the lymph nodes are involved, the size of the tumor, if they received therapy before surgery, how well did they respond to that therapy? There are so many variables that play into predicting the risk of recurrence. But we have good science, and we have some tools that we can use on an individual patient basis to try to really better put that into focus for the patient.
Are you involved in any new studies or treatments for cancer patients?
Yeah, so one of the things that we're very proud of here at GBMC is that we have a very active clinical trials program, which is a bit unusual for a community hospital. You tend to think of the big academic houses, the Johns Hopkins, Memorial Sloan Kettering, et cetera, as being where clinical research is done, but we can do it in the community as well. And right now we have almost 50 active clinical trials that we are enrolling patients on here at GBMC, and that's been something that the hospital and the organization has been very devoted to supporting. We're very appreciative of that in the Oncology Center.
We touched on this a little bit. Someone wants to know what impact did the pandemic have on your current patients and the ones who have been deemed survivors, which you believe all are, but what kind of impact did it have on them through?
Yeah, boy, in so many different ways. I mean, it's been tough on everybody, but especially those in the cancer world. I think about it on so many different layers. Coming to the clinics, coming to the infusion center, having to come alone, which is hard. You don't have your loved one right by your side. So, just on a very day by day basis, that was very scary. I think feeling especially isolated. I mean, aware of their greater vulnerabilities. Many, stayed home even more and longer than, say, the rest of the community has when it came to reemerging. Um, uh, Increased hospitalizations and the loneliness that goes along with that, especially early on. It's been hard, but one of the things that cancer patients and cancer survivors, I should say, are so known for is just being so resilient. I mean, they tune into that in an effort to get through their own experience, and so superimpose COVID on top of that, and I think they had those skill sets to draw on to help get through COVID as well.
This may have been a small positive, but someone wants to know, did social distancing and staying home decrease secondary infections in cases of the regular flu in your patients?
Without a doubt. I mean, I have had 0 patients get the flu this year. I mean, that's remarkable. I mean, and I can't remember the last patient who had a cold either. I mean, it's really, really amazing how few upper respiratory illnesses we've had to deal with in the cancer space and also outside, in the regular community. I mean, there's something to be said about that. I mean, I think we're going to learn about that, or learn from that as we go forward. I mean, masks may be here to stay, at least in the oncology setting, for a long time, even when, God willing, COVID passes by, because it's really made a big difference.
Yeah. Can depression affect recurrence of cancers?
So that's a really good question. I don't think we can say directly that it does. I mean, a lot of times we hear about depression and stress as being a trigger for cancer recurrence, and it's hard to say conclusively that that's true. Now, that said, if somebody is depressed and as a result they're not taking their medications, that might be important in preventing the cancer from recurring, or they're not going to get that follow-up test because they're just kind of blue and melancholy and they just don't want to leave their house, then I can see how indirectly depression might affect a recurrence risk. But as a direct cause, I don't think so. That said, depression is so important and it's so treatable, and it's so relatively common in our cancer survivors that we really very much want to focus on helping our patients emotionally. Even if it doesn't affect their recurrence, it sure does affect their experience, and it needs to be front and center when it comes to addressing it.
Again, the holistic approach there.
Yeah.
How do you determine the chemo method for patients, oral versus infusion, and is one more effective?
So if one is more effective, then that would probably supersede the other. So we always want to have the most effective therapies, as long as it's not just about effective, it also has to be well tolerated. If something's very effective but horribly tolerated, well, that's no good. So if it's well tolerated and more effective than that, that would be the first start. And then we really look at what our principles are that guide us, that are based upon very important clinical trials that have been done that show which are the best drugs to choose from. And sometimes there's an array of choices, and then we really try to match that to the patient. We try to meet the patient where they are. We try to invite them to be part of the shared decision making so that we can come up with a solution that is best for them. It may be a treatment that's more convenient, or a particular side effect that is less likely because of drug X versus drug Y. So it's a blend of all of those things together to figure out what's the best strategy.
Where can one find the most current research on gene mutations that may cause cancer, especially the lesser known genes? And they give an example. CHEK2 is one.
Yeah, so we've come to understand that a small proportion of those with malignancies have underlying predisposing genes, and the ones like CHEK2 are the ones that one can inherit from mom or from dad. And we actually have a very good genetics program here at GBMC, championed by Jennifer Billier, who is our geneticist. And so we will oftentimes refer our patients to Jennifer if we have reason to suspect that there may be a predisposing genetic mutation that might be helpful to know about. There's lots of resources available from your own desktop. The NCI, something called cancer.net, both have search engines that you can go to, and you can literally punch in the gene and it'll bring up information. And lots of the companies that actually now test for the gene, they have very good portals that allow one to go and really understand the genes, including those very rare ones that were mentioned.
A couple of questions just coming in about radiation. The first one is it common to have pain or nerve discomfort years after radiation?
Yeah, it's not uncommon. I mean, a lot of it depends upon where the radiation was administered. Areas that have lots of nerves to begin with are more sensitive, so you're more likely to have long-lasting nerve injury in those locations. The dose can be a factor as well. So less radiation is less likely to cause long-lasting side effects than more radiation. So it's not at all that uncommon, especially in what I do in the breast cancer patients that I care for.
And how do you determine when a patient needs radiation?
Well, it really depends upon their clinical scenario. I mean, again, we follow good science, we follow good guidelines. If it's medically indicated, they will receive it. I mean, it really depends upon the scenario. Not everybody needs radiation therapy. It's all driven by what is the standard of care for their particular cancer.
Couple questions here about letrozole. First of all, what is it?
So letrozole is one of the tools that we use in the breast cancer realm. It's a pill. It's what's called an aromatase inhibitor. So it actually diminishes the production of estrogen in women who are postmenopausal. And it can be used either in early stage disease to try to prevent recurrences of breast cancer, or we can use it in advanced disease, oftentimes in combination with another medication, to try to prevent the cancer from progressing. It's one of many drugs, oral drugs, that we use in the breast cancer space.
So it lowers the estrogen for
Correct.
cancers that feed on it.
Correct.
Okay.
Right. So not all breast cancers, but those that are driven to grow by the presence of estrogen.
How do you suggest treating joint pain that accompanies letrozole? Are there other options?
So that's not an uncommon problem on letrozole. For many patients, it's mild and they can work through it. But for some, it can be a much more limiting and it's occasionally debilitating side effect. So first of all, we always make sure that the patients are aware that can happen, and it may even help in deciding whether we choose to use that drug or something else if they already have pre-existing joint issues. So, for example, there's a drug tamoxifen that's related that doesn't cause joint issues as much. So sometimes it'll affect whether we use the drug in the first place. Physical exercise and activity has been shown to lower the likelihood of developing bone joint pains or makes them better in those on letrozole. There are medications that can be used, although it's always hard to use one medicine to chase away the side effect of another medicine. Acupuncture has been tried, physical therapy has been tried, and has been met with some success.
Yeah, I feel like.
But
no, continues.
But if it's severe enough, then it's time for a change, and we wouldn't continue with a drug that's really making somebody suffer.
Is it newer than tamoxifen? I feel like I've heard so much about tamoxifen, but not a lot about letrozole.
Yeah, tamoxifan's been around for about in the United States since 1977, so for 44 years, and the aromatase inhibitors, and there's 3 of them that are approved in the United States, have been around for about 25 years. So they're not that new. They've been around.
How long does someone have to stay on it?
So it varies. A minimum, if they're tolerating it and if they have not recurred, would be 5 years. And there is now some evidence to show that going longer in many, but not all, with early stage breast cancer, out to 10 years may be of further benefit. So it's really depending upon the individual story, how well they're tolerating it, what their innate risk was in the first place, and what their bone health is. There's a whole bunch of factors that we look to decide whether to stop at 5 years or go longer.
A couple more questions while we have time, and this involves proton radiation therapy. Would you clarify the difference between proton radiation therapy and standard radiation?
Yeah, so you're hearing a lot about proton radiation therapy. If you watch Jeopardy at night, you'll see the ads every night. I know I do. And so it's something that's relatively new compared to the old standard radiation therapy, and there are many facilities around the country that have opened, including one here in Baltimore, and soon one will be opening in DC as well. Proton beam therapy is a different way of generating energy that can hopefully kill cancer cells, as opposed to photon, which is what is the more conventional radiation therapy. Proton beam therapy seems to be slightly better in certain situations, including pediatric cancers, cancers that are difficult to treat, such as spinal tumors. One of the advantages of proton beam therapy is that it seems that there is less of an innocent bystander effect to some of the surrounding tissues. And so in certain situations, that makes it better. It's not necessarily better than standard radiation therapy across the board, however. And it's important to know that, because standard radiation therapy, which is still used for most patients, is still absolutely adequate. Newer is not always better, but in some ways it is.
And is it available at GBMC?
So it's not. So if one were to see our radiation oncologist, and if they deemed that proton beam therapy would be better for that particular patient, then they will refer that patient.
Okay.
I mean, it's all about what's best for the patient.
Couple late questions coming in real quick. How to determine the use of zoladex versus lupon?
So those are what the question is about a particular shot that is actually used to an indirect hormonal therapy. We use it in prostate cancer. We use it in breast cancer sometimes. They're actually pretty similar, quite honestly. They are uh, really the same drug with different names, almost. And I don't really have a preference for one or the other. Honestly, in the real world, what sometimes drives it is what's more affordable to the patient. If the insurance company is going to cover one better than the other, whichever is going to be less expensive to the patient is the better drug. But I think from an effectiveness standpoint, they're really about the same.
All right, finally, last question. Can soy products have an effect on cancer? And
You know,
while I'm throwing that in there, I'm just going to say, are there any other red flag foods that you want to mention?
so let's talk about it kind of broader, and then I'll come back to the soy. So, I
Okay.
mean, it's well understood that unhealthy lifestyles are a contributor to not only developing cancer in the first place, but also the recurrence of some cancers. And so, um, if what I recommend to my patients across the board is regular physical activity, exercise, ideally exercising almost every day, although I know that's hard to do, but moderate aerobic exercise up to 150 minutes a week, which is like 5 times a week, 30 minutes at a time. Hard to do, but that's the standard to which we should aspire. Um, and then a healthy diet, Mediterranean-like diet. I don't necessarily recommend fad diets or really intense diets. I think a Mediterranean diet is a healthy lifestyle. It's very sustainable and it is relatively low in carbohydrates, but not devoid of carbohydrates. You'll sometimes hear people say, "I can't have any sugar." Well, no, that's not true because sugar is a normal nutrient for the body. The body does need some sugar. It just doesn't need excessive sugar, and it doesn't need all those carbs, those excessive carbohydrates that our society has turned to in the last 30 years. So a Mediterranean diet and good physical activity. The question to soy, and usually that's asked in the context of breast cancer, because for a long time there was a concern that soy might actually be harmful from a breast cancer standpoint because of the thought that it contained some form of estrogen. Well, the truth is, if you look around the world, the countries that use a lot of soy in their diet have a rather infrequent incidence of breast cancer. So in Southeast Asia, breast cancer is a lot less common than it is here in the United States or in Western societies. So there's really been a rethinking of that, and there's actually some science to suggest that, believe it or not, soy may be protective from a breast cancer standpoint. Now that's basic science; it's in labs and cells, so it's not in big human research, but it gives us some further thought. So I've changed my tune. Years ago, I used to tell patients, don't take soy, avoid soy if they're a breast cancer survivor. Now I say, with moderation. I don't tell them to go out and do a soy supplement, although maybe that is the right thing to do. I just don't know that. And I don't tell them to avoid soy like the plague either anymore. I think it's most things in moderation, which is probably a good truism for
Yeah.
for life in
Yeah.
general, right?
And a good way to end this conversation. Such great information, Dr. Robert Donegan. Thank you so much for being with us today and taking all the questions.
You bet. Thank you. So
All right.
nice to be with you.
Take care, everyone, and we'll see you next time.